Hi, good evening, everybody. Welcome to Nivarana's Public Health Forum. For those of you who are hearing about Nivarana for the first time, Nivarana is a public health information and advocacy platform which was started in 2022. We aim to bridge the gap between public and public health by making complex information accessible and easy to understand. We wish to empower people with the right information with the hope that more people would begin to be bothered by the public health practices in the country, understand what is lacking, and ultimately demand things to change. Public Health Forum is one of our initiatives where we have solution oriented discussions to problems with experts in a panel and in the audience. Today, we are going to talk about a very important issue, which is tuberculosis. As we all know, India had aimed to eliminate tuberculosis by 2025. And as 2025 is only a week away, it is evident that India is off track. And today we are going to discuss how off track are we in eliminating this age old disease. And to discuss this, we have speakers who are working at the grassroots levels in the country. Our first speaker is Dr. Pavitra Mohan, who is a pediatrician by training and the co founder of Basic Health Services in Rajasthan. Basic Health Services is a not for profit organization that strives to provide high quality care to marginalized and remote populations. Dr. Pavitra has closely worked with individuals suffering from the dual burden of silicosis and tuberculosis. Thank you for joining us today, Dr. Pavitra. Our second speaker is Dr. Vasundhara, who is a primary care physician, a microbiologist, and a lab medicine specialist who works not only to empower communities through awareness, but also leads capacity building of laboratories in remote and rural India. She works in underserved parts of Bihar, Chhattisgarh, Jharkhand, West Bengal, Odisha, Uttar Pradesh. Wherever you think there is need, Dr. Vasundhara is there. Our next speaker is Dr. Deepak Chandrabadani, who is a surgeon. He recently left JSS, Jan Swasthya Sahayog. He was a surgeon practicing in Jan Swasthya Sahayog, which is a hospital catering to the needs of poor and marginalized tribal communities in Chhattisgarh. He has seen a lot of patients with extrapulmonary tuberculosis, and he'll be sharing his experiences with those patients today. Our next speaker is Dr. Sensi, who is a public health physician who did her MD from St. John's, Bangalore, and is currently the assistant director in Kerala Health Services. She was the district TB officer of Idukki district in Kerala for 5 years from 2019 to 24, and her novel initiatives and advocacy for TB elimination, low-cost sputum sample transportation chain, and multi-sectoral engagement have won accolades from NTEP at state and national level. And our last speaker, Nandita Venkatesan, Nandita is a data journalist, and I'm sure in the TB world, everybody knows who Nandita is. She's a health policy leader with 7 years of diverse experience across media, public health research, and policy advocacy. As a survivor of MDR TB herself, she has been a strong voice for all TB patients in this country and advocated for better access to healthcare for tuberculosis in the country. Our session today will be moderated by Swati. Dr. Swati Krishna is a public health physician and researcher who completed her medical education MBBS from Jubilee Mission Medical College, Thrissur, Kerala, and community medicine from CMC Vellore. She's currently an assistant professor in the Department of Community Medicine at Bharati Vidyapeeth Medical College in Pune, Maharashtra, and is also a fellow of India Health Policy and Systems Research. And she closely works with state and district NTEP machinery in various forms of tuberculosis elimination program, and she's also an advisor for Nivarana. So over to you, Swati, to take the session forward now.
Thank you, Parth, and thank you, Nivarana, for taking up this crucial discussion. We have our eminent and diverse panel waiting here. But just to set context, let me share a few key messages from the India TB report 2024 and WHO Global TB report, which were released couple of months back. So we all know that the whole world is in the run for NTB, and this is defined by some targets in terms of the number of TB deaths, reducing it by 90%, reducing the new cases of TB, that is TB incidence rate by 80%, and bringing down the catastrophic cost affected families, TB affected families, to 0% by the year 2030. And India went a step ahead, telling that we would achieve it on an accelerated timeline by 2025 itself. Now, this is what we mean by NTB by 2025. Now, this would require at least 11% decline in annual TB incidence rate in India, while we are only at a 2.5 to 3% decline. Now, let's see what the world is in terms of these achievements or indicators. We are largely off track. The TB incidence rate has achieved only an 8.3% reduction, whereas we were expecting 50% reduction by 2025. Number of TB deaths again has reached only at a 23% reduction, and more than half of the families affected by TB are facing catastrophic costs. And India, of course, is the world's largest contributor to TB cases. 26% of world's TB cases are from India. And we are also leading in multi-drug resistant TB burden as well as TB deaths. Now, one important point is about the use of WHO recommended rapid molecular diagnostics for diagnosing TB, which is essential to reduce the number of missing cases of TB being diagnosed, as well as to rapidly diagnose rifampicin resistance and hence prevent the emergence of multi-drug resistant TB. Now, this usage of WHO recommended molecular diagnostics is globally only 48% people get that, and in India it is just 21%. Now, the catastrophic cause due to TB in India, there was a recent study done by Susmita Chatterjee, which showed that majority of the TB affected families do suffer catastrophic cause, the highest being for extrapulmonary TB. And the world at large is lagging behind a lot in terms of achieving various targets for NTB, and we have refreshed our target milestone to the year 2027, and we have very ambitious targets in front of the world to achieve by the year 2027. Important ones among them being achieving 100% molecular testing by the year 2027 and increasing TB treatment coverage and TB preventive treatment coverage to 90% by 2027. Now, NTB goals at present seem to be a distant dream, but we have some positive trends. Annual incidence of TB has globally slowed down little and started to stabilize. TB mortality continues to fall. Reporting of cases, new cases are at the highest, and we have been able to maintain reasonably high levels of treatment success rates. Now, these are the important messages from our TB reports, which released recently. Now, with this context, let us start our discussion. Let me go to Nandita first. Nandita, while most of the, both the TB reports have had many critical acknowledgements in terms of meeting NTB targets. But what is not spoken much about is the detrimental shortage of drugs which happened in NTP in our country last year and the after effects due to that. Like it is still continuing in various parts of the country. As a TB survivor yourself, what do you think are the implications of this break in supply chain for patients as well as the program? Over to you, Nandita.
Thank you, Swati, Nivarana, for organizing this discussion on TB and the road to NTB by 2025. That is what we are all here to discuss. So, regarding the shortage of TB medications, to give you, first of all, to understand how it impacts, I would like to break it down to exactly what happens when a person contracts TB. So, when someone contracts TB, there are two ways. Either you have the drug susceptible form or the drug resistant form of TB. In the drug susceptible form, all of the first line medications essentially work on you, and you are treated in a matter of 6 to 9 months. So that is the general course of medication. And in drug resistant TB, what happens is that your treatment duration generally goes up to more than a year to even 2 years in many cases, uh, because of the fact that the bacteria has gotten resistant to a lot of the first line medications, primarily rifampicin and isoniazid, and then you need far more advanced and far more what we could say as toxic or more difficult medications rather, in order to treat drug resistant TB. And these medications often have a range of side effects on people who are taking it. If you go for a susceptible TB, your side effects can be something as nausea, vomiting, you experience rapid weight loss, or you have sweating, you have cough out blood, but when you but you know that your treatment will end within 9 months, 6 to 9 months. In terms of drug resistant TB, your side effects and complications can really double up. People suffer side effects such as discoloration of the skin, problems in the liver, problems in the kidney. In very extreme cases, you suffer from complete loss of hearing, which is what I had to undergo because of a medication called kanamycin. And you can end up completely with a life-altering disability in many cases. You also suffer from peripheral neuropathy, which is really tightening of the feet, and your feet becomes really numb. So all of this you are suffering. So my point of putting all these aspects is that it really takes a mile for patients to go and end up at the finish line, because you have to really walk down this path before you actually get some semblance of hope that you will finally end up in the finish line, maybe a year, or in worst cases 2 years later. Of course, now we have shortened, the government has thankfully introduced a lot of shorter regimens. For example, with the use of bedaquiline and delamanid. Some of these, for bedaquiline, for example, we had fought a patent opposition case as well for it, in order to improve access to bedaquiline. So this is the background in which I wanted to present to everyone, that this is the background that generally a patient sees. If in this now, in all of this, if you have shortages of medications, what essentially happens is that there is a disruption in treatment. Now, disruption in treatment is not the most ideal and advisable thing for TB, because the one thing that you are constantly reiterated for every person with TB is that you have to have your medications every single day. Otherwise, you will end up developing further resistance. So this is something that is reiterated by the doctor constantly, that come what may, you may suffer the side effects, but you have to have the medications. So what happens is that if the treatment is interrupted, there is possibly a scale, there is possibly a chance that the patient could end up getting more resistant, which has not yet been documented. We haven't had any research or anyone coming out and discussing as to what has been the implications of the NTEP shortage that happened. Second thing is that even though the patient wants to adhere to the treatment, because there is the fear that, okay, I don't want my condition to worsen. But here what is happening is that essentially the fault, quote unquote, is not on the patient's side. It is essentially on the other side, where he doesn't have the medications right now itself. So the person will have to run from pillar to post uh, in order to get medications. And I think the very third implication, I think, is the fact that there is TB, patients with TB suffer what you call as catastrophic health expenses. A recent ICMR study that was released about a week or two back also pointed out that 45% of 45% of TB patients suffer from catastrophic health expenses, and and one of the major drivers of catastrophic health expenses is medications. Fortunately, in TB we have the medications free, so to say, at least the TB medications. Patients suffer beyond that for a variety of reasons, which we can discuss. But the point here being is that when you don't have these medications, persons with TB will essentially have to go outside of the health system to go and find medications elsewhere. And he would have to essentially spend from his own pocket, already adding to the burden of expenditure that the person is already facing because of other things. For example, you need very strong nutrition. You need to have very good quality food, nutritious diet, all of which for which does not come very does is not very cheap. So we for all of that, a patient could end up getting more added amount of expenditure because of these medications. So, and often it happens from what I've seen last year, is that the medicines that ran short for that period were essentially MDR TB medications. So they are not produced on a mass supply basis, so it is not easily available in say, if I run out of a medicine today, it's not easily available in private pharmacies. A person is essentially will have to travel to possibly another city, or have to travel long distances in order to get the medication, because well, a maximum of the medicines is supplied by the government. So private pharmacies don't really have any incentive to stock up TB medicines themselves. So I think these are some of the dimensions that generally happen because of this.
Yeah, correct. Right, Nandita. And even some drugs like bedaquiline are not even available in private pharmacies. And the whole agony which patients had to undergo, and still in many parts of the country, which is still ongoing, it is really heart-wrenching to see. Thank you, Nandita, for that. Let me move to Dr. Pavitra. So you work in Rajasthan, which notified about 1.65 lakh persons with TB in last year, 2023, and have a high notification rate of 203 per lakh population. Can you shed some light on the state of TB diagnosis and treatment in Rajasthan? Over the years, have you noticed any change in the situation? Dr. Pavitra, over to you.
No, thank you, Swati. I think I'll just briefly give you a context of South Rajasthan, where we work, and many other parts of Rajasthan, where there are high levels of out-migration. There are high levels of undernutrition. Many people who migrate out work in occupations which are hazardous. The least hazardous is something like construction, even which exposes your lungs to dust and the most hazardous is silica, the stone carving and mining, which leads to silicosis. So in general, the lungs are diseased, the people are undernourished, and in cities they would often live in accommodations which are very overcrowded. So there is a high chance of both contracting TB and transmitting it once you get it, both because of undernutrition as well as your lungs are damaged because of exposure, the occupational exposure. So it is in this situation that the prevalence of tuberculosis is very high, and so it's not by being tribal that you contract TB. It is by being exposed to these realities of lack of food or of working in hazardous occupations that there is a high prevalence. Now, within that, from South Rajasthan, the access to diagnostics. So one is that there is many times they contracted in a city but come back, right? I mean, the male migrant who's working in a city would get exposed, but in presence of an unfamiliar health system and lack of effort by the city health system to reach out to migrant population, many would come back to the villages where they come from, and So the access to diagnostics, the CBNet machines are few and far between, right? I mean, in a district there would be one or two at the most, and these distances are large, right? I mean, these are also both Western and South Rajasthan. The distances are huge because of either desert or hills. So the nearest place where CBNet facility would be available are often very far from where people live. In some of our clinic areas, it could be as far as 70 kilometers away, and in absence of any clear, uh, you know. Uh, uh, plans to actively transport sputum or for microscopy. I mean, microscopy is another thing that I would like to bring. That very few and far, access to digital X-rays in these places. So people do run around to get an X-ray from a private laboratory, which is of a decent quality, etc. And access to diagnostics would be in the nearest CHC, which, as I said, could be from anywhere from 30 to 70 kilometers away. Uh, while there has been an expansion of CBNet machines in the state, there have been procurement of more machines and more digital X-rays, but they are still very inadequate, and many of them may not. So there may be a machine, but there may not be cartridges. So besides the shortage of drugs that you mentioned, which is also huge in our areas, has also been a shortage of diagnostics from time to time, or the machines go bad and then they won't, be repaired for weeks, during which again the diagnosis becomes a problem. So while there has been an expansion in some capacity, it is still highly inadequate. And administrative problems like not having a lab technician or the machine not being repaired in time or the supplies of the cartridges not being in time affect and delay the diagnosis itself. Uh, Digital X-ray, as I said, is another issue where, again, very few hospitals in the state, CHCs, very few CHCs would have both a machine and a man to operate it and a functional machine. So, in absence of this, there is a huge delay. Now, because as I said, the distances are huge, and people are also, many of these live on the borders of Gujarat. So, they would rather go to a private practitioner in Gujarat to get access to treatment and to diagnose. And interestingly, in Gujarat also, they often don't get sputum tested. So there would be an X-ray, there would be other tests done, but and they would be started on ATT, which is not recorded anywhere. There's no NICHE ID, and a large number of people therefore end up paying. Many people who come to us, we run not-for-profit clinics in 6 such locations in southern Rajasthan, where when people come, many of them, and we did a study a couple of years ago, right after COVID, to see what people spend. Some of them come with as much expenditure as 80,000 rupees, right? And come in often in very advanced stages because they would have gone to a private practitioner in Gujarat. There they found that the costs are extremely expensive. The disease gets advanced. They don't have money to continue the treatment, and then they would come back and yeah. So the other problem with the CBNet is a large number of people have had tuberculosis in the past, right? I mean, the patients who present to us, many of them would have history of having contracted TB in the past, where CBNet may not be the most kind of useful test, and I'm sure Vasundhara will talk more about it. And then there is, a huge dilemma of initiating the treatment, and they get delayed or, not appropriately diagnosed. So these are some of the absolutely basic problems of distances of. There would be things like these are also areas with high mortality, so they wouldn't be able to continue the treatment beyond. I mean, you go to a PHC, and if on that day the sputum is not being collected, then you go back 30 kilometers and then are never able to go back. Then you say, okay, might as well go to a private practitioner, get started, leading to a huge delay. So that's broadly the scenario. The question you asked, has it improved? There has been a greater attempt at having more machines and having more X-rays, but the entire complement of a person and a machine which is functional and accessible is still a huge. We are very far from that.
Right. Right. So everything in general is adding on to the catastrophic costs of the patient as well. Right. Thank you, Dr. Pavitra. Let me move to Dr. Deepak. Dr. Deepak, you are a surgeon working in rural Chhattisgarh, which is home to diverse tribal population. As a surgeon, what's your experience with tuberculosis?
Hi, everyone. Thank you, first of all, Nivarana, for arranging this, I would say, very wonderful thing. Because for me, I mean, for the last 4 years since I was working there in JSS, I mean, seeing the pulmonary TB is, I mean, it's one thing, but the counterpart, that is extra pulmonary TB, it's like not only the disease, its severity, but the severity of undernourishment these people have is really worrisome. And I don't know on which basis such speculations they like sort of create in mind that they are going to end TB in 2025 or 2030. Sorry for my words, but I am really surprised after reading such fancy articles, I would say. I would like to stress with the people, if you'll permit me.
Yeah, Deepak.
Deepak, we can hear you.
Can I share? Yeah, can I share? Okay.
Yes, please.
So, yes. So, and these pictures are, I mean, not like, so it's everyday story basically. So this is a young, I would say, middle-aged gentleman who came to us with these non-healing ulcers with chronic discharges for 4 years. And one can see the hair, the chronic hair loss. And then this extensive scrofuloderma, a lady who was taking Augmentin for almost 1 year. And then this psoas abscess, the collapsed vertebra, spine. Then this is cutaneous TB. Then the various presentations of abdominal TB, then this involving the digits, then this various, I mean, completely disseminated, involving, I don't know whether any organ is left. This gentleman had some features of TB meningitis, then pulmonary TB, and then perforation is very much visible. And then operative findings, this genitourinary TB. So these are some pictures like which sort of explain what are the condition actually on the ground level, and uh, where what we have actually one should like look for. I mean, the first thing is the training is very important part. I mean, I don't know whether be it it can be done either at the level of the surgical training, or either in the form of task shifting, which is very much needed. I would say that is what I have learned in the last 4 years. Without task shifting, we are not going to sort of counteract this disease. This is the like not a 5 year or a 10 year or 15 year, or for that matter of sake, even a 50 year of story. It is going to take almost 200 years from here, if all the possible efforts are put in. And then the second thing is which I just mentioned, the task shifting thing, which is very much necessary, like doing the basic thing. First of all, like if we start with the basic, the commonest extrapulmonary TB, that is TB lymphadenitis or the pleural TB. Uh, I mean, how many, this is like on this forum, I really want to ask how many of our doctors are really trained uh, 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 knows these forms. Uh, at least I would say we can train these people. I mean, at the level of MBBS also. And then what are the availabilities? Whether we have basic facilities like uh, doing uh, FNACs, lymph node biopsies, even pleural taps, ascitic taps, mini laparotomies, diagnostic cystoscopies, whether these facilities are available at these facilities. And when such patients or the patient having these conditions, they have to travel almost 200 to 250 kilometers sometime. And I came across like some around 15-20 patients who have traveled almost for 400 kilometers to reach our centers, and they have like uh, uh, have plenty full of USG reports and then whatnot, I would say, but they never diagnosed. The problem is the suspicion, whether they are suspecting that this could be TB also. For example, the first picture which I have shown, the gentleman has many people said that you have some form of malignancy. So this is, I mean, the truth which is prevailing in the not only in the uh, I would say the rural parts, but in most of the parts of the country where people are not aware.
Hello, Dr. Deepak.
Pulmonary TB document released in last year, 2000 in March 2020, I think 24 or 23. The entire this is surprising for me because I have seen like almost with my team and there almost 1500 patients in last 4 years, and seeing uh, 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 so hi-fi things. I mean, in terms of like diagnosing, we do not require such hi-fi things. For example, the picture we have shown to you, the extensive genital scrofloderma, we just did a simple pus Jaden staining and it was 3 plus, and see the lady was suffering in the like hope that somebody will diagnose him, or and she'll get the treatment. Similarly, PPT to show the what are the delays in these. I mean, to diagnose uh, extrapulmonary TB with the help of this study which we have done in last 3 years. Here we can see. So system level delay. So patient level delay are when patient is not aware of his condition, when patient have many regions, whether there is agricultural season, they do not have enough money to go to a proper hospital where they can be diagnosed. And then health system level delays are when the hospitals do not have facilities, and the various other regions. So one can see the number of days which are variable from like for TB lymphadenitis, which is the commonest form, it varies from somewhere around 3 weeks to 1 year. And then similarly for pleural TB, and then one can see it can go up to, for example, in genitourinary TB, up to 5 years. And TB meningitis is something which is diagnosed earlier because of its severity. People usually pick it up, but it also takes time. And by the time they pick it up, usually, I mean, these people, uh, this disease in the country. And I mean, then these patients require not only the ATT is one aspect. I mean, most of the times our training is like for TB, you have to give just ATT or what all drugs, but these patients have, I mean, the undernourishment and the amount of care they require is totally lacking in our system, I would say. And my words, I mean, really, I mean, uh, I'm going with tough with my words, but this is what is a reality on the in the ground. And then the surgery when they require, there are no surgeons which can provide them surgery at appropriate, I would say, the cost and with the skills, because this is I want to share the lung patient who had disseminated TB, and then this patient underwent a laminectomy. So with this lung and with this pulmonary function test, I can say in best of the medical colleges, they will not get the anesthesia clearance. But you have to take risk to manage these conditions. This
Right.
is what I want to share.
Right, right. So harrowing stories about extrapulmonary TB, much less talked about. Thank you for sharing those stories with us. Um, let's move to Dr. Sensi. Dr. Sensi, you are an officer from the government healthcare delivery system and who led some innovative advocacy and community engagement initiatives in Idukki district of Kerala. So, how important do you think are awareness about TB and community participation during these times? Will you share your experiences with us?
Thank you, Swati. Am I audible?
Yes, please go ahead.
Yeah. Thank you, and thanks to Parth and Nivarana for continuing this discussion. It is quite humbling that I have been out of that routine most 8 or 9 months, but still I am working with some of the programs here and some other places to work. So I think since you mentioned that I'm an officer of the government healthcare delivery system, yeah, it is true that it has its own benefits in terms of the fact that I do have dedicated staff. We do have, some senior treatment supervisors.
Dr. Sensi, your voice is not clear.
Not clear.
If you could remove your headphone or.
Okay, I will try. Am I audible now?
Yes, better.
Better.
Yeah.
Okay, so what I was trying to say is that, okay, so we do have a system and we do have HR dedicated for this program, since we know that TB elimination program is this one national program which has a dedicated vertical system in the actual healthcare delivery system. But then, yeah, and some of the initiatives that you said, like the innovative things that we've done here, they do came as the best practices from Kerala in the India TB report, which is what people are mentioning and they're asking us to replicate. One was pertaining to logistics and one was pertaining to advocacy and community engagement. And then we did one medical travelogue in a tribal setting, which was showcased at RR at Kolkata. And we did a campaign called Yes Campaign, which means Yes, We Can End TB, a project that we wrote for school children. And that was conducted among 75,000 students in our district. And it is now going to be replicated in Lakshadweep. The travelogue and the this project. So it is heartening to know that some of the work that we do at the grassroots level in our own smaller district system, it's being appreciated and they are taking up and trying to scale it and replicate it in other settings. But I should say that it is not an easy job. Like, how do people get to know that? I'm pretty sure a lot of good work is happening in several districts across the nation. And some of these work, we do get to see those work being commented in the India TV report once in a year when it comes out. And then it is a learning process for us. But I am not sure if there is a lot of cross learning happening, across platforms where we get to share our experiences and people get to learn from it and replicate. In my case, what I tried to do was when I was convinced with some of these projects, and I felt was that there was a larger purpose that could be done with this, observing the success that it delivered in our district. I took the responsibility of going beyond my routine work and trying to get the attention of our ministers and people at the district administration on a personal level, trying to convince them that please look at this, please try to post it on social media, please post it on your Facebook so that more people will get to see. So this was really an ordeal. At times, some of the projects that I have done were launched on official platforms by several ministers in our state. But we know that everybody has a lot of set priorities, and TB is not everybody's priority. We have to understand that. So that is the same thing with so we need to go a mile ahead and go and convince them that you need to propagate some of the good activities that we're doing. And then another thing about healthcare delivery system is that I joined as district TB officer right before COVID pandemic struck our state, and everybody had to deal with an unparalleled situation. So that is the time when we remember, if you remember, our health system collapsed and all of our attention got diverted. And that was the time when we had to go ahead and remind people that even every time when you cough, it is not COVID, it can also be TB. And even the health staff who were familiar with the forest symptoms, like it was written the back of their hands, they start forgetting about TB altogether. So
Right.
we have to do this additional effort in creating awareness once again, not just for public, because when we say create advocacy and awareness, we always think about public or people
Yes.
outside our system. But we had to go ahead and remind our own staff and people that we do have existing issues. So now we know after COVID, new and new emerging diseases are coming up, and the same HR, the same human resource being used for all of this. So the lot of burden is right there, and it is about shifting priorities and always remembering what is to be done. So I think that is the importance of awareness, because if you're not fully aware, then faulty awareness means our actions can also be faulty. I remember this one time when we tried to discuss with a social media influencer who used to speak a lot about health issues on social media, who had great followers. When we asked her to support us with a COVID TB awareness, the first question that she asked was, "Is there still TB in Kerala?" Because Kerala, as
Right.
we all know, has high literacy rate, and everybody is supposed to be aware of things happening. But people who are notice things around them even forget that TB exists. The same thing
Right.
happened to the movie star who we tried to get us an advocate for Nikshay Mitra.
Mm.
That is the problem that we have. Like, even if we say that we are creating awareness, how much of it is effective?
Right.
And the next thing is community participation. We do know about the definitions that we have learned over time in public health about community participation. It's very nice to learn that, it's the active involvement of community members in decision making process. They get to contribute their ideas, they get to share their knowledge, get to take part in the planning and implementing and all of that. And then we know active involvement, using the local knowledge that they have, empowering them, and doing a collaborative process is all part of community participation.
Right.
But when you try to boil this down and actually try to do something, we cannot bring all of these spokes together. We sometimes fail to bring all of this in one platform. For example, let's start with COVID. I mean, during COVID, we all focused on using the vulnerability data that we had for reverse quarantine. In Kerala, we had Akshay Kerala campaign to strengthen TB notification and detection activities. We were told to do telephonic active case finding. All of that we focused on case finding activities. And what we needed to focus on was reminding people about this. So I would like to mention one of these advocacy activity that we did, if time allows, as an example. So this was called Nalu Mani Pukal. Nalu Mani Pukal in English means flowers that bloom at 4 o'clock. So this was the name of the project, and the title was a low cost, partially digital campaign empowering women and spreading awareness. So we realized that we were trying a lot. I mean, I worked in Idiki. Idiki is the largest district in Kerala with the lowest population density, with more than 90% of its geography covered with forest. And it's a lot of it has its own difficulties. So our thought process was we were having these new NAT sites for testing. We were scaling up our molecular testing activities. We were having a robust split and collection transportation mechanism in place. But then again, why are not more people coming in for testing? How can we improve? Because our district is a district which is a forerunner in elimination activities. Our prevalence rate is very low, our incidence rate is very low. So we need to travel that extra mile to make sure that every last person is identified. So this program was focused on reaching old homes, everybody in the district. So how can we do that? I mean, it is not possible to use our HR. I mean, they have a lot of things to do. So we decided to collaborate with one of the largest women's network in the world. It's called Kudumbashri. So this was essentially set up by the local self-government to empower women. So they have these neighborhood groups, which are also called Ayalkutams in Malayalam. These neighborhood groups that operate at grassroots level. In this Kudumbashri, which has a three-tier system. So each neighborhood group has a leader. This leader could also be an ASHA worker or a health volunteer based out on some of the houses in that area. So we devised this project and we discussed with the Kudumbashri Mission district program manager. Now, again, we had to do a lot of convincing. Finally, the honors of the program was on us, but it was important to get them on our side because we had to convince all the different, in the three-tier system, we had to convince the highest tier, all the leaders that a message has to be passed through your WhatsApp, a message has to reach the neighborhood groups and tell them that they have to participate.
Right.
So they did, and we got the district administration to support.
Right.
But our entire, the small group had to monitor this day in and day out. And this partial digital campaign, we had feedbacks in the form of Google Forms from all the groups. So I thought of, let's see how this works. Let's see
Right.
how far this goes. And
Right.
I was surprised by the turnout. Like the Google Forms were being filled by these women at the grassroots level. And we finally had a data that 150,000 approximately women participated in the program.
Right.
From their own data. Our health staff did not pick it up. We had, and I had this golden opportunity to go and showcase this to the health minister. She was, very happy with this, and she decided to replicate this for Viva program.
Right.
Viva program is something to tackle with anemia.
Right.
So, I mean, that is in a way that we try to do this.
Right, right. So that's what. So political commitment is very important, and governance, leadership, their cooperation indeed make a difference in turning around these programs. And adjoining to what Dr. Deepak said, you also said that awareness among the health system HR, including doctors, very, very essential to take forward this journey. Now let's move to Dr. Vasundhara. Dr. Vasundhara, the guidelines of NTEP say that we have to perform upfront NAT. Or NAT should be the first investigation to diagnose TB on a presumptive TB person. But what is the ground reality? How is TB diagnosed in remote areas? Over to you.
If it is diagnosed, yeah. All right. So thanks a lot, Nivarana. And also thank all the people who helped me understand this illness and the issues from Jharkhand, Rajasthan, Bihar, Odisha, Chhattisgarh. So, and they give me a lot of inputs if I'm not there. So thanks to all of them. I remember all of them. So I'm not going to, because the diagnosis is so hodgepodge, so messed up, that I'm not going to, if it's okay, I'm going to tell you about issues at every level, not just with the CB
Yes, sure, sure.
So if I start from the ground, so I was talking to some Ashas or Mitanins or Sahiyas, and they said that they don't know anything other than the 4 symptoms: fever, cough more than 2 weeks, weight loss, and loss of appetite. So they don't look beyond this. If it's a single, just weight loss or fever, firstly, that training itself is wrong, because it's not well-being that we are looking at. We have this like rabid dogs going behind only one illness, while it should be well-being in the public health system, right? Now, and they are target driven. So they said, Hamara target, if people can understand Hindi, it's like ek ya do per year if we diagnose TB. Yeah. So we don't make more effort. So then there were others who said that we go once in 3-4 months to check for this. Okay. So there is on one extreme is this once in 3-4 months round from this is from my health workers in Orissa, to saying that suddenly the government wants us to meet our targets or something. So somehow we have to get patients to submit samples. And the lab that it was going to said that, we used to get saliva samples also just because of this target driven approach. Yeah. So at that level, it is that. And then all they do is like, okay, if I suspect TB, then I may or may not have a sputum cup at that time. Tell the patient to go. Now, TB is still a disease of stigma. You just cannot tell a patient you have suspected TB, you should go and get your sputum checked. Where do they go? People have, Pavitra and Deepak have told how far they have to go for that sputum testing, right? Without any support for transport or 3 bus changes. Why would I go to get myself diagnosed with TB of all the illnesses? Yeah. And so then the next level, okay, I'm not feeling well. I go to the Jhola Chhap or the Bengali doctor who keeps on giving me antibiotics for my cough. Yeah. And then, or if I fall prey to some greedy private practitioner, that the kind of tests that are done at that level are like Montu test, which is a skin test, or an IGRA, which is also not favored, or you will get thyroid test and vitamin B12 and vitamin D and calcium and all that. And the most favorite of all is Vidal for typhoid. So, that again delays. Or if you get to someone who does your CB nut, yeah, that is 2,500 rupees. We should think of who's the person getting TB. Yeah. Is that a person who can afford this 2,500 rupee test? Yeah. And that's if you fall in the hands of a private practitioner. Often they don't want to do all this because then they have to notify the disease. Yeah. So they will refer them somewhere. They'll keep giving them antibiotics and they'll not get these tests done and refer them to some other person or to some other place. Then we have options of the district hospital or an NGO, like say what Pavitra is running or where Deepak was. Those people, they would somehow gather funds to do diagnosis. They may or may not possess a molecular-based test. I'll come to those issues. And then we have the district hospital level or the Jila Hospital or the medical college level. Now, what kind of lab tests? So in private, as I said, if it's a CB nut, it can cost about 2,500 per test. And in a district hospital, huge volumes. Okay. Then in the NGO and trust hospital, somewhere where we have microscopy, which is a quick, affordable test. And really, it doesn't require that much skill because it has literally 2 colors. The bacilli are pink and the background is blue. So if someone can, spend time on this, the sensitivity is also pretty decent for a smear positive case of 2+, 3+, whatever the bacillary load. So you are saving that patient from, additional cost. Turnaround time is like 30 minutes versus 2 hours. And there was a study done I think in Tamil Nadu, where the cost of test of microscopy is roughly 300, while 1,000 and up for the molecular based test. And if you go for drug sensitivity testing, it is 7,000 and up. So why not invest in microscopy also? We are not even talking of fluorescent microscopy, which is like 10% more. It picks up more things, more bacilli. So it's a quick test. especially for, and then you can send the patient home. Again, we have to keep thinking, who are these people who are getting TB? How are we helping those people? Yeah. So just saying that we have increased molecular tests, and now this 100-day campaign of announcing we have increased or we will increase or have increased the number of tests. So again, coming to the lab technicians. Now the technicians, even for microscopy, the kind of technicians I train, they have just read about it. They forget molecular testing. They have just read about it, not even performed the test. And they have seen pictures. Then you are expected them to perform tests, yeah, without even having learned about it. So I would question that in a country like India, where we have such high number of cases, or where diagnostics is so essential, what is the quality of education that the lab techs are getting? Yeah, and we are spending time doing all this. Why are we afraid of a simple thing like microscopy? Just because, and it's labeled as a complex test? Not at all. No, as I said, two colors. No, and then think about the training, and then this 100-day campaign has started. In the people I spoke to, nowhere have they increased the number of machines, nowhere have they increased the number of HR, and they already have, at the current level, they already have 1 week samples pending in the molecular tests, which are supposed to have a turnaround time of 2 hours. So 2-hour test, it's 1 week pending. Yeah. So there's something seriously wrong in this. And then if like Pavitra said, like if a cartridge is not work, slot is not working in these places, it's not easy to get a technician. Then we have TrueNat. Of the two tests that are there, CBNAT is like a fragile flower. It needs AC, it needs dust-free environment and all that. It's the Gene Expert, sorry, not CBNAT, Gene Expert. And the TrueNat, on the other hand, it does give a lot of indeterminate results. Okay, so you need to repeat it. Yeah, again, that's another, adds up another 1,000+ rupees. Do we have that bandwidth to add that? Yeah. I also see varied protocols being followed by different people. Some prefer TrueNat, some people prefer Expert. So that is also another thing. Then another Pandora's box, if I open, if it is positive, it has to be sent for LPA or line probe assay for sensitivity testing. You won't believe that if we are talking of drug resistance and all that, the turnaround time to get back the results can be as long as 3 months as of today. Okay. So it is, you may say in your numbers so many LPAs done or so many samples received for molecular testing, but what is the turnaround time? That's the most important, right? And now with this 100-day campaign, I fear that the samples will increase, and again, others will be sitting there. We are not thinking of the lab technicians. Are we even thinking of the safety? And often they don't sleep well, they don't eat well. So are we thinking of all those also? If you want the private practitioners or the NGOs to, support, are you supporting them with the infrastructure? Are you supporting them with the supplies? Are you supporting them with lab personnel? Yeah. So all this. Now I have actually got stuff to show, like just trying to understand which of these collection tubes or containers are acceptable. You send it in this, they'll say, no, this is leaky, invalid or inadequate. Okay, so we need you to send it in a bigger this thing. Yeah. But
Falcon tube,
50 ml Falcon tube, but we cannot give you enough because you don't give us the number of tubes back, the number of tubes that we gave you. Yeah. So then our lab techs start giving this. Now, how do you expect to spit in this? Right. So just to get one thing sorted is so frustrating, going back and forth in these little things. So from an eagle's eye view, everything looks, the numbers look fantastic. But it's probably a drop in the ocean of what we actually should be doing in the diagnostics field. Where is the helpline if if it's an indeterminate or invalid result? Who knows what to do? As I said, the quality of training is so pathetic that this all is not given. All these concepts, and it's just like we tell you to do this, you do this. So this is the yeah. I'm just telling in a very short abridged version of the issues with diagnosis of TB, not even thinking, and this is pulmonary TB, I'm not even
Right,
thinking of extrapulmonary. If you
right,
look at
right.
the samples that come, if extrapulmonary is 30% of all TBs, which is also tip of the iceberg, then nearly a third of the samples should be of non-pulmonary forms, but they are not, which clearly shows that it's not being picked up enough. So yeah, so there is a lot of firefighting happening, a
Right.
lot of ripples under the smooth, calm thing, or the big names, all Nikshay, Nikshay, Nikshay kind of. It's
Right. And the staff which we have currently under the program, they're serving double the population they are required to. That is also one reality,
yeah,
which at least in our part of the world, I'm working in rural Maharashtra basically. So the population norms which they have set are based on the earlier census
yeah,
data or whatever it is, and the population has changed dramatically,
exactly.
especially post the pandemic. So we really need to redefine or restructure the HR also.
Mhm. Yeah, I think, yeah.
Right. Thank you, Dr.
Thanks.
Vasundhara. One more question to Dr. Pavitra. So you spoke about the issues in Rajasthan. So how do you see in future, as in, like, what should be prioritized by the program NTEP? What barriers should be addressed first? Your thoughts quickly on this.
So I think we should look at TB elimination is not possible only by NTEP. I think that's something we need to understand. We need to, and the things we need to really, if we're really serious about it, we need to improve nutrition, food availability, and nutrition. We need to have safer occupations.
Right.
And within NTEP, we do need to address both nutrition and occupation as an important kind of determinants. I mean, in the areas that we work, there are these stone carving industries which cause a lot of silicosis and therefore also concomitant silicotuberculosis. There is no kind of a focused program to early identification and management of silicosis, which is a different kind of a ball game altogether. So because you're looking only at it from a TB kind of a lens, but when you have an occupational disease, how do you prevent that as well as detect TB early and then tailor your management accordingly? So having some of those focused interventions in areas which are food scarce, which have hazardous kind of occupations are an important determinant, which NTB alone is probably, it's not possible, but they need to have that vision and need to bring in other stakeholders to address that. Within NTEP, I think there needs to be a very rapid expansion of diagnostics, but more importantly, I think, and I mean, we see it, of course, every day that when patients come to us, they probably many times come from 30, 40, 50 kilometers and they pass through several PHCCSs which offer TB diagnostics
Right.
treatment. But the reason they don't go there is the behavior of the staff and availability of staff. So it's not even the skills.
Right.
Skills would come after that. And it's not kind of my assumption. There was recently a study by ICMR in the areas that we were, I mean, in the tribal South Rajasthan, they also showed that rude behavior of the staff is one of the important barriers for tribal patients. This is a study published in Indian Journal of TB in 24, which said that
Right.
the rude behavior of staff and this delayed or erratic incentivization is one of the key reasons why people are not able to complete treatment. So I think the overall the NTP can at least try to be a trigger because it is of such a high priority to improve some of these systemic issues
Right.
of behavior, of availability, of treating people with dignity. I think in
Correct.
absence of that, it's impossible to and I think it's common sense, right? I mean, there is, as you said, there's a shortage of human resources.
Hmm.
There is difficulty in accessing, and therefore need for much greater investment in getting diagnostics and treatment closer home, and
Right.
overall a system being a bit more empathetic. So it's really not rocket science, but the problem is that TB cannot be eliminated by poorly functioning health systems and by an inequitable society where you don't bother whether a person is dying of silicosis or not. So I think these two things, we at least as activists, I mean, if the program has constraints in addressing, so we need to keep raising about uh, the need for improved nutrition, improved availability of food, safer occupations, and hugely expanded access to diagnostics and access to a more empathetic health systems.
Right, right. Very, very valid points. Dr. Deepak, you spoke about training being a priority, like among doctors itself, TB, extrapulmonary TB, sensitization about management or maintaining high index of suspicion for TB. That should be a priority. Apart from that, anything else would you like to add for the program's priority list?
Uh, so first thing, which I also mentioned, the task shifting is very much necessary. We have to teach the basic skills which are required. It's like
Right,
we cannot keep them up to only the, I mean, whether the surgeons or the physicians or to anyone. We have to teach people. I mean, I have come across so many good people in last 4 years, those who are not even, like, those are only 12th pass, but they do
right,
things so nicely. Even a graduate can sometimes be surprised to know their skills, like doing gastric aspirate for childhood TB, and then doing sometimes doing FNACs and lymph node biopsies. And these people all are just, they get the training with, I would say, with in from good people. So the task shifting is something we really need whenever we talk about the dealing TB, or for that matter of sake, any illness in the country.
right, right, right. That's very important as well. Dr. Sensi, I mean, right now you have shifted your role as DTO to assistant director, but still, from your experience, what do you think the program should prioritize in the forward journey?
I think the program should prioritize not on just on numbers, but also on getting, actual results in the field. I feel like lately, over the past few years, it is true that we have to accelerate our journey towards achieving the goal of TB elimination by 2025. And in your introduction, PPT, we clearly saw the gaps
Right,
that are still existing.
right,
And mostly we are just trying to churn out these numbers, especially with last year, these TB Mukt Panchayat,
right,
we have all these indicators that come up, and some of the, okay, then when we look at the indicators closely, are we really aware what these indicators mean? Like generally, the people who are working in the system itself,
right,
how to make sure that the indicators are reflected in the actual work that happens.
right,
For example, like we discussed earlier, one indicator is the number of tests that happen for every, I think, 1 lakh population, or 10,000 population.
1 lakh.
So, 1 lakh population.
Hmm.
So, to reflect that, all of these things that we discussed, the awareness that need to be generated at the grassroots level so that more people come forward and do this, and then strengthening the molecular testing sites and having enough HR at the molecular testing sites. Because some of the problems that we face here, now I'm a medical superintendent in my hospital. Now I have low lab technicians and a low number of lab technicians here. Without the adequate number, it is very difficult. We have both CBNet and TrueNet in our laboratory. And they have to do all the routine tests at the Taluk hospital level. And they also have to run these two machines. And I, being a previous DTO, know the importance of doing the test on time for several reasons. But then sometimes our HR is burned out. They cannot turn 24 hours into 48 hours. So having adequate HR and then having these things effectively implemented at the field level so that everyone takes it as and have ownership of the program is very important.
Right, right. Ownership is extremely important. Dr. Vasundhara, any suggestions for priority list for the program?
Well, so I'm telling that it should, like Pavitra said, na, it should be how we define well-being and not just like TB, and then you forget even the comorbidities with TB.
Right, right,
If you look off for those four symptoms, for example, and then you're only focusing on pulmonary TB. Now, what I wanted to mention before is where things are working are where the health workers are spending time with the patient in counseling, where there is a support system either to get samples from patients, or like I know in BHS, there is a person who actually accompanies the patient, or meets the patient where they have to get their X-ray done or the sputum done, because cities can be quite intimidating for uh, people from remote areas.
right,
So, for every step, a support system. And there's another place which provides transportation money for them to reach the clinic. They
right,
provide them food when they come to the clinic. Or they even give them like a 200 rupee thing that if they have lost their day wages, then. Another, so that, and then another private practitioner I know, again where things are working is where there is a constant communication between the lab and the provider. Yeah, do people have that patience to do that constant, although it shouldn't be the case, but that's where things are working. And still, even despite that, you get the result in 1 week. So if that was not happening, then it would be even longer. So this counseling, then seeing that the patients are supported, then as Pavitra said, empathetic care, looking at the person as a whole, than as a disease inside that person, and then you don't care about anything else. Uh, However, that patient, if they have something else or not. So these are the things that have to be included in this program, not like this rabbit dog approach, no, of 2025. I don't know where the math comes from that you can eliminate a disease like this if it was so simple. So yeah, so these are the things I would uh, include on what I'm missing in the program, besides looking at the health of lab technicians and of the peripheral workers also. But
right,
talking is extremely important. Talking to the patient and having patience
right.
is extremely important. So 2025 is a first goal.
Right, right, right. And I would like to add in terms of training, lab technicians, other cadre posts, and even medical officers need training, more training. There is no two way about it. We see many of them are not aware. Fresh graduates of MBBS who enter service, government service, are not even aware of the or like basic national health programs even, which I found very disheartening. Well, on that note, let's open up the floor to questions from audience. Parth, do we have any questions? I see few conversations in the chat box. Is Aditi still there?
I think even Tom has raised a lot of questions. So, Tom, if
Yeah.
you would like to unmute yourself and share your thoughts.
Yes.
Sure. Firstly, just thank you so much for organizing this discussion. It's been really, really interesting. And thank you so much to all our panelists. I feel like I've learned a lot, and it's fantastic that you have expertise in such diverse but also interconnected areas. I had one question for Nandita, but maybe others of you can also address it. I'm interested to know, is there any news on, whether the drug shortage, when it might be addressed by, I've had several of my patients, I live in Lucknow, and several of my patients have also, they required significant out-of-pocket expenses to buy MDR drugs. So yeah, just any news on whether this is likely to be resolved anytime soon?
I think Nandita is not there. She has left. If anybody else would like to take that question.
No, I won't hazard a guess. I really don't know whether. The only thing we know is that at least for the non-MDR patient, the drug supply has resumed. Uh, there was a long period where it was not for MDR. I'm not sure. And the I think the larger question, Tom, is also that how do we make our supply systems proof? Because even if they come now, when will they again get out of coverage? Do we have enough planning and systems in place to avoid the shortage in future? Because as Nandita had earlier said, that one episode of a few months of not having drugs can cause um, you know huge problems both for individual patients as well as for transmission of the disease and for converting to MDR. So I think what we should really be asking the governments is what have they done after the last supply shortage to ensure that it doesn't happen in future.
So we are still getting reports of drug shortage from various parts of the country, even now, even though it had stabilized by past few months. I mean, last year was really bad. And for those of you who are not aware of it, but NTEP has its own separate system of procurement of drugs and consumables. It is comparative. Uh, could Okay, I'll continue. It has its own system, and by which the Central TB Division procures all the drugs and consumables from Global Drug Facility, which is World Bank funded, Stop TB Partnership funded. And from there, it flows into the central government's medical stores, store depot, and from there to the states, and then down to the districts, and then down to the peripheral health institutions, which could be nursing homes, clinics, or medical colleges, or PHCs, whatever it is. So it is all separate for TB, different from the general drugs and consumables. The state drug store is separate for TB. District drug store is separate for TB. So at least by system, there is a robust mechanism to maintain that supply chain. There is a portal dedicated for supply chain management in NTP called Nikshay Aushadhi. That is, access is available only to administrators. So all the drug request entry and the drug supply, each pill is accounted for in Nikshay Aushadhi. But what has happened, as we know from sources and news reports, of course, is that the tenders which were not placed on time. Some of them got cancelled because some companies were blacklisted, and that kind of snowballed into a lot of things. Of course, this is what we know to outside. And to recover back from that, states were immediately asked to procure drugs on their own, whereas states do not have a mechanism to procure these drugs, which has been happening centrally for a long time. So again, states faced a difficulty to procure drugs at low costs or low costs and the required amount. Hence, the shortage happened, and the repercussion is still happening. But it was a little bit stabilized, but again, we hear news about shortages happening. So we really don't know when it will actually be solved. Yeah, that's about it. Any other questions?
Mohsin, would you like to unmute yourself and ask?
Yeah, so my question is with respect to the stigma associated with tuberculosis. So while I was traveling in the villages of Bihar, so rural Bihar, what we found was I talked to someone and I asked what is the problem with that particular home? So they had a specific marking outside that home, and they said that home has TB. And then I asked what is the problem with that having tuberculosis or it gets cured? So they said, no, it's not like that. And then they had their own concepts about it that once in a family, if there are cases of tuberculosis, even marriage alliances for good amount of time, they don't send marriage alliances. So it's it's very even though when we think at from our levels, like from health professional levels, we think that it's a curable disease. We are concerned about the prolonged medication time, but the stigma associated is at par with other diseases that we see, such as AIDS, and it's not short of that. So how do we tackle this stigma? And like at another point, what I had seen is like the patient was from one particular block and they get registered in another block, so that like when they go for taking the medicines, like nobody gets to realize that yeah, they are from this particular block, and that is the lengths they go to avoid being noticed that they have this particular disease. And I have this perspective, like I'm from Kerala, but I have been in Bihar. So the contrast is very big. The contrast is such that like while my brother-in-law gave me a story where like once he diagnosed a case of spine TB in Kerala, like the patient's relative fainted hearing the diagnosis of spine TB. That difficult it was for them to grasp it. While in Bihar, like while during my internship times, we had prayed that let this patient have TB because the alternative diagnosis was non-Hodgkin lymphoma. So that is how different it is, and like still I can't find that like the stigma, like why so much stigma and how to fight it is like my query over here. Thank you.
So, maybe I'll just very briefly speak about it. There isn't much time, but yeah, I mean, you're right. There is a lot of stigma associated with it. Historically, it has been there with certain diseases, which are considered to be because of your own ill deeds of the past. That kind of makes you, whether it's leprosy or or tuberculosis, and they're also more evident. You cough, and then people around you come to know that the disease, and yeah. So I think one of the ways, and you're right, that many people tend to travel long distances to go to a provider which is far off rather than one that is closer, to be avoid seen as taking treatment, or going to a hospital which is considered to be a TB hospital. One of the things, I mean, besides, I think one just needs to talk more about it, more freely about its causes. How does it get connected? What relationship does it have with food and with occupation, or with the bacillus, the bacterial origin of it, etc. One thing that we have found useful in our own practice is to have a peer support groups, and to have peers coming to the at a common place together talking about it. So they get a lot of strength from each other, understand from each other, and talk about it more freely, where their attendants and family members also join in, and you talk about it, and others also share their stories. So that kind of becomes a stronger. In cities, you have these TB survivors network, etc. In rural areas, there aren't, but I think there's a huge need. So we started creating some of these through at the moment with the days, fixed days in the clinics. But we plan to expand that group of TB survivors, so to say, and their family members, to start talking more about it, and also to do some collective action to eliminate the disease. Well, we started seeing that a lot of people who have recovered from our clinics, they actually go around helping others. They sometimes bring them on the motorcycle from 60 kilometers without charging. They go to their houses when they are a bit demotivated and stuff like that. And that's how we thought, let's start creating a network of people. So that seems to be one idea. The other is that with partner organizations, we are going around in different platforms talking about the disease and its origin in Gram Sabhas and others, where you could, the more you talk about it and speak about its origins, that it is not with your ill deeds, it's because, you've been excluded, or, because, there is undernutrition, or there's a bacteria that causes it. The more open it becomes to have a
Right.
conversation around it. So,
Right, we need to normalize the talking about TB.
yeah.
Last week, I was in a TB survivor's home, and the son was telling, he's an old farmer who's cured of TB. So his son was telling, "Itna nafrat mat karo." Uh, Patients, being a patient, what they had to face was that much of hatred from their community, which was like very sad to hear. So it is the same story everywhere, I guess, across the country.
Yeah.
Uh,
I think
any-
one of the issues is that doctors also often don't disclose
right,
the diagnosis. They say you have some
correct,
disease which will
correct.
take 6 months to treat, etc. And so
Correct.
not talking about it doesn't help, because they feel
Correct.
that by telling them it will become a
Yeah.
big deal. But telling about the disease and then telling more about its causation, etc.,
Correct.
tends to kind of make it more normal to talk about it.
Right. Okay. So we'll take one last question if anybody has a question, or else Aditi is in the meeting. Aditi, would you like to ask something?
Thank you so much. It was a wonderful session. Really getting to hear so many views about on the same topic. So right now I'm in the Northeast, and I realize that the context is so different, and that's where my question is: are we really designing for context specific interventions? Like you're saying that access, whether it's hilly or it's remote, getting the samples across, as well as managing to reach people through different modes. My question is also around the symptomatology itself, the locally prevalent diseases that predispose. One of the things that we found during the Ashwasan campaign was in Jharkhand, the commonest, other than cough, the commonest symptom was loss of weight, whereas in Odisha, the commonest symptom was fever, whereas in the Northeast, it was, in Rajasthan, it was actually chest pain. And in Madhya Pradesh, it was blood in sputum. So are we really designing for it like this? Are we capturing enough information? So is there enough money parked in research as well for this? Like in the Northeast, the nutrition is great. You don't see this much undernutrition that you see in, say, Chhattisgarh or Jharkhand. But we're still seeing a lot of TB. So that's my question, really.
Question, Aditi. So do you see any other comorbidity like diabetes? Is it prevalent there? Because
there is.
So who are the
cancer.
people who are getting TB? Are they in a closed space living together? There should be something other than the undernutrition part that is making them more susceptible to this. Yeah, and like I said, the symptoms, we have to go beyond those 4 symptoms, of.
What about HIV prevalence?
So yeah, I mean, all those things. What are the other predisposing factors? It cannot be like a healthy walking individual getting TB. There should be something which has caused a disturbance in the cell-mediated immunity and has caused the person to acquire it. So, or overcrowding and then breathing the same air, or so yeah. So it would be hard to believe that they are healthy individuals with tuberculosis.
Definitely. I mean, the fact that they have tuberculosis, that itself is to an extent defines an illness. But I'm speaking on a relative scale, having seen the issue in Jharkhand versus seeing the issue in Nagaland, where I am right now. There's such and the response to the medication is also very different. So because you don't see the kind of side effects that you see with extreme undernutrition, but cancer prevalence is definitely higher. So and comorbidity in terms of cancer is also seen. So therefore, the disease management also takes a turn to that extent. And diagnostics, definitely. I mean, you're not only thinking in terms of TB, you have to expand it beyond that to rule out cancer, for example. So, yeah, there are questions to be answered on that front. But thank you so much for for your kind sharing of this to this
Right.
extent. Thanks. Yeah.
Your point on context is very relevant, Aditi. It is indeed that TB epidemiology itself is very diverse in our country. What is operating in Northeast might not be the factors operating in other parts of the country. So, yes, the program needs to be flexible, which it is to a large extent compared to previous times. We need to innovate, we need to adapt. So all those context specific measures need to be taken, which is why this clear division of authority is also there. You have broken it down to district TB center and down so that we could innovate according to the needs of the community which we are working in. So that is indeed really important. So I think we'll wrap up this discussion. It was wonderful talking to everyone, sharing all the experiences. I wish we had more time, maybe discuss more on this. And it was wonderful knowing from various parts of the country the diverse perspectives. Over to you, Parth.
Thanks, Swati, for moderating today's session, and thanks to all the speakers and all the participants who engaged on this topic today. If you have any other questions, you can always email us and we'll connect you with our speakers. Our email ID is nivarana.for.india@gmail.com. It's in the chat box. We're definitely not ending on the most positive note for our year, but we have definitely a long way to go, and it's important to realize that there are some shortcomings and then adequately prepare for the next year. So thank you all for taking our time this Monday evening, and we hope to stay in touch and do more of such relevant discussions in the coming future. Do sign up for our newsletter. It's a monthly newsletter. We won't spam your inbox. Once a month we send one email, and in which we'll share what discussion will be happening next. So a Merry Christmas and a Happy New Year to everybody, and we'll see you all next year. Thank you.
Thank you. Thank you
Thank
for
you.
all who joined online. Thank you, panelists.
Bye. Thank you.
Thank you. Bye. Merry Christmas.